initiative in this holy month. And I hope you are having a good time in Ramadan. And I pray that our fasting and prayer are accepted. And I hope that this pandemic will be finished soon and we will come back to our normal life before Eid. So we will have more enjoyable and prosperous Eid holidays. Tonight is very special time and great occasion, and it's personal honor to invite my professor and my teacher, Dr. Torowob, the chairman of radiology at Hospital of Sick Children, University of Toronto City in Canada. And Dr. Torowob is well known in Saudi Arabia and all over the places by his support and training to international graduates, and he's well published in the literature. Tonight he'll be speaking about MRI in neonatal encephalopathy, and this will be the last session in Ramadan and Eid holidays. Whoever have question, please write it in the chat, and Dr. Torowob will be checking it and answer it whenever he feel appropriate. Thanks, Manno, and it's an honor to have you. I hope you are here in Saudi Arabia physically, but at least we can see you and learn from you again. Thank you. So you can share your screen and start, please.
Right. So thank you very much, Maki. Maki is very kind with his words for me. He's a very good friend. So today I'm going to speak on MRI of the term neonatal brain. And this is just one of the old photographs. Let me forward it. This is from a time when I visited Riyadh and Maki hosted me, took good care of me. But I've known Maki since more than 10 years. He's a very good friend and a good colleague. We worked together in Toronto at the University of Toronto. And we studied together for some of our exams, and it was good fun. I learned a lot from him. So thank you, Maki, for giving me this opportunity. Just before I go on, let me introduce my institution, the Hospital for Sick Children. It is a very unique institution. I'm very proud to be part of it. It's a privilege and honor to work at this institution. So this is a photograph from 1896. Somebody taking an X-ray of a young child of the ankle. And you'll remember that in 1895 was the time when X-rays were discovered. So within a year, sick kids had an X-ray machine. So the history of radiology at sick kids is very long, traditional, and very well recognized, particularly pediatric radiology. So today we are going to speak on MRI. But you know that ultrasound is a very fast screening technique in neonate, great for germinal matrix hemorrhages. CT is very good for acute hemorrhage and trauma. In the past, we used to use to look for calcifications in CMV. And now we only use it rarely when we want to solve problems for sinovenous thrombosis with contrast, and mainly for trauma. Most often, the most sensitive and specific study for neonatal neuroimaging is MR. And we use that a lot, and that's what we are going to talk about. So just to start off, what do you think is normal and what is abnormal over here? Just to give you a little glimpse of how the term neonate brain looks so different from an older child or an adult. Myelination is not completed. Can you see my arrow, Maki? Okay. And you can see it is hypointense on T1, and it is bright on T1 when it is completely myelinated, and hyperintense on T2 when it is unmyelinated, and dark on T2 when myelinated. So this posterior limb of the internal capsule is bright at birth after 37 weeks, and that's a very good milestone for myelination at term. So in this talk, we'll be reviewing and educating on causes of encephalopathy, how to optimize MR technique, appearances and patterns of HIE, talk of a few differential diagnoses, and touch very briefly upon medical legal aspects. Some of the information that I give you will be in these papers, and they are available for free downloads. in radiographics and in the Indian Journal of Pediatrics. So causes of encephalopathy, the most common cause is hypoxic ischemic encephalopathy. I would say 85 to 90% of the times. But don't forget that metabolic causes, trauma, infections, and congenital disorders can also present like encephalopathy. One important thing to remember is hypoxic ischemic encephalopathy has a specific clinical definition. It includes acidosis. It includes multi-organ dysfunction. So when you do make a diagnosis of HIE, make sure that you know your clinical history very well. I've just put some facts over here just to let you know that preterm infants are at higher risk for HIE, and a significant proportion of them will have either mortality from HIE or significant deficits. Now, before you even think of doing an MR in the neonatal brain, it's very important that you ask yourself several questions. And at Sick Kids, we ask these questions, without which we will not do an MR if we don't get this information. One is the exact age of birth. The reason for that is HIE in the preterm involves more the white matter. So it looks very different from the term neonate, and you need to know the exact age at birth. Try to time the insult. So you should try to get a history of when there was encephalopathy. Was there fetal distress even before birth? Or did it happen right at birth or after birth? Because it impacts findings. You know that diffusion-weighted imaging normalizes in 5 to 7 days. So it's important to know when the insult to the brain started. This third history is very important, particularly if encephalopathy has occurred a few hours or days after birth and the child was otherwise born normally, then you think of other causes other than HIE, metabolic or infective causes. And this is a good example that I'm showing over here at the bottom on the right side. This was a patient with onset of encephalopathy a few days later, and you can see this pattern, which is very classic for maple syrup urine disease. Usually HIE doesn't involve the dorsal brainstem or the cerebellar white matter. And you can see this diffusion restriction is involving mainly the myelinated areas. Also make sure that you get history, which increases your diagnostic confidence. So we like to know what the Apgar's was at birth. Core arterial pH, less than 7.14 or 7.15, particularly less than 7 is very significant acidosis due to ischemia. Hypoglycemia, because you know where to look for. This is a good example of neonatal hypoglycemia, which occurs in the occipital lobe. Also remember that you could have double trouble. You could have hypoxic ischemic encephalopathy with hypoglycemia. You could have a metabolic encephalopathy with other findings. You could have trauma. So think of double etiologies that happens in a small percentage of cases. Very important, medication can make a difference to your MR appearances, and hypothermia as a treatment can make a difference. I will show you in the next slide the impact of phenobarb on the appearance of MR spectroscopy. For example, the preservative in phenobarb, 1,2-propanediol, it looks like lactate on the intermediate MR spectroscopy. The only thing is that 1.1 part per million, whereas lactate is at 1.3 parts per million. They're very close together. If you don't know this difference, you might mistake it for lactate. We'll talk a bit about hypothermia and how it impacts diffusion restriction. So just to tell you about MR spectroscopy quickly, in the very young child or neonate, Na is lower. It takes 2 to 3 years for Na to come to normal levels. And this was an example of a child who had both lactate and was loaded with phenobarb, which has a preservative propane 1,2-diol. So in this MR spectroscopy at 144, you know that lactate is an inverted doublet at 1.3 ppm. This is 0, this is 1. And propane 1,2-diol is at 1.1 ppm. So you can see how it can confuse you for the presence of lactate. The importance of knowing what medications have been given. Coming to hypothermia and how it impacts findings, there are a number of papers on this. We do know that hypothermia reduces injury to the brain. What is interesting is that most papers will show you that irrespective of whether you use hypothermia or not, if you have a normal finding, it suggests a good prognosis, which is good. If you have abnormal findings, it seems to have a similar prognosis like the pre-hypothermia MRI studies. You will find, though, that with hypothermia, you will have a very bad story, of acidosis, poor APGARs at birth. Hypothermia has been given, and the expected appearances on the MR are much less. So that happens very often. But when you have these normal findings, it's good. Abnormal findings, similar prognosis like otherwise without hypothermia. We'll come to how to actually do an MR and how to get the baby to the MRI unit. This is very important because remember that these neonates are very sick, and you have to think of their safety during transport. If you can afford this neonatal incubator, these are very expensive, then this saves considerable time in transport and improves neonatal safety. Also remember that when you are doing an MR on a child, and this is one of our magnets with Leanne, our MR technologist, and an ICU transport nurse, you need to be aware that you need to protect their ears very well. So we use triple acoustic barriers. We put ear plugs in for them, we put ear muffs on them, and then we use this acoustic hood to further decrease the impact of any sound on their very delicate hearing mechanisms. So all these precautions you have to take. So in terms of safety, this is something that a neonatal transport nurse taught me: stable. You have to worry about sugars, temperatures, breathing, blood pressure, the various electrolyte levels, etc. And don't forget the emotional support for the parents, because you can imagine what happens to a young mother or a young father who just have had their child and they see their kid in this condition. So you have to be very sensitive to the emotional aspects of the parents too. We often monitor our kids with small appropriate pulse oximeters. The usual pulse oximeters may not work very well, so you have to get the correct ones. Also know that neonates who have suffered damage due to ischemia will often tolerate a lower saturation value of 88 to 90. That can often be a normal. So we speak to our neonatal transport nurses and our NICU teams very closely to make sure that the neonate doesn't suffer any harm from transport or whilst they are in the MRI magnet. I think this is very important. One thing, if you remember from how to do an MR well, is to use the most appropriate coil. Now, we are fortunate because we are a pediatric institution, so we have dedicated neonatal coils, which are small FOV coils. And you'll see the smaller the diameter of the coil, better your signal to noise. Sometimes if you can't really afford these coils, which can cost $20,000, $30,000, you can use an E-joint coil, which can also work very well. You will have to do some trial and experimentation with that to make it work well. The other thing to remember is the T1 and T2s are different in the immature brain. The immature brain has a lot of water content and has very long T1 and T2 relaxation times. This makes it very important that you increase your TRs so that you get better signal. Also, with increased TR, you will throw up your imaging time per sequence a lot. But because there's a lot of water in the brain, you can increase your echo train length. So you can bring your time back of the sequence to almost the same like you would for your routine T1 sequences. And that really helps to improve the quality of your MR. Let me show you an example. This is our routine T1 at 420 TR in the same neonatal brain. This is the optimized T1. You can go up to 950 because the TR relaxation times are very high. It still is a T1 weighted sequence. The same thing on T2. You can increase your TR quite significantly. This is our routine. This is our increased TR. And you can see at the same time in the same brain, almost at the same amount of time per sequence, the images are so much more sharp. And of course, this is because we have saved time also by increasing the echo train length significantly. What about diffusion? How do you use that in the neonatal brain? Diffusion is the most important sequence in your MR study of the neonatal brain. And in preterm, some people think that a lower B value of 800 is useful because it gives you better SNR. It is well known that the lower the B value, better the signal to noise, but lesser the sensitivity. If you use a higher B value, the sensitivity is much more, but the signal to noise is less. As sick kids, we are very used to a B value of 1000, like in adults. And in most places that I know, we use 1000 B values for preterms and terms because we're very used to this and we understand the significance of what we see. And there are some academics who do suggest that if you're using a 3 Tesla magnet, you can go up on your B value to increase the sensitivity of findings. In very specific situations, we'll do that, but not as a routine. Let's come to MRI technique. I prefer to do the most important sequences first, which to my mind is diffusion weighted imaging. This is what normal looks like, and this is abnormal. The second sequence that I like is T1. And this is what a normal plic will look like. And this is what abnormal will look like with abnormal bright signal in the posterior putamen and the ventrolateral thalamus. We'll come to this finding. It is a finding of grave prognostic significance much later. Some people in my group do like to use the T1 images first before the diffusion because the diffusion has much more noise. So they would like the child to settle down with a sequence which is much less in terms of sound. And then we use T2s, normal versus abnormal, see the increased T2 signal in the thalami and the basal ganglia. And then we use gradient echo T2. This is just to show you an incidental thrombosed cortical vein seen as a linear susceptibility. So this is our general protocol and axial DWI. In terms of T1, I just want to point out that we use a 3D sagittal T1, which is a MP-RAGE or SPGR sequence. The T1 axial sequences that we used to use previously, axial spin echo, we don't work that well in terms of performance. The 3D sagittal T1 with reformats is our gold standard for T1. And what is very important also is to use a very good high resolution gradient echo sequence. If you have SWI, use that. If you have Swan on your G sequence, use that. It is very high resolution. And Philips has similar matching high resolution thin slice gradient echo sequences. For MR spectroscopy, our standard is either an intermediate or a higher TE value MR spectroscopy in the left basal ganglia. MR venography, I said over here only if needed, and I'll come to that later as to why you should do it only when needed. So this is showing you gradient echo T2 sequence and its value. It helps not only show hemorrhages within the brain or the ventricles, but it will also show you things like sinovenous thrombosis. Now, many times on time of flight MRV, we see artifactual flow voids. So we don't do MR venography unless we see suggestions of thrombi within the venous sinuses on gradient echo or T1 sequences, in which case we would do an MR venography, and sometimes we'll have to do a CT venography to confirm that. And this shows a thrombus in the torcula, shown as susceptibility in this particular gradient echo T2 sequence. So in terms of technique, I already told you about MRI technique for spectroscopy. I'll touch upon one more point of this in the next couple of slides. You may think of additional sequences, like doing a shorter T if you think of a metabolic cause. Routinely, when we only are imaging for hypoxic ischemic encephalopathy, we would do just one MRI sequence at 144 or a higher TE value. In MR venography, we can use time of flight or phase contrast. Again, remember that do it only if needed. There are a number of pitfalls that are associated with this. So when you really suspect sinovenous thrombosis, you need to do it, and you need to do it properly. Just to come back to MR spectroscopy, to let you know that on the short T, lactate is upright. On the intermediate, it goes below the baseline. And on the long T, it goes up again. Now, these are very useful, the intermediate and long one, because the macromolecule and lipid signal, which can confuse and sort of hide lactate, have died out. They have a short T, and then you can see lactate very well. But there's one caveat, because many of us, we do our MRS on 3 Teslas, and we image our neonatal brains at 3 Tesla. It's very important to remember that on 3 Tesla, many times on the press sequence, where they use 3 pulse sequences to localize the walk. So those are not really accurate, and they can cancel out lactate signal. So this is from a paper in AJNR, which shows this from 3 different vendors as to how that effect occurs. MR spectroscopy really gets suppressed on the T144 compared to the longer TE. So if you have a physicist who can correct that in your 144 sequence, you can do that. But if not, try to be sensitive to this artifact that occurs in pitfalls in lactate, and you may have to use a higher TE. Coming to T1 weighted images, how do you use them? You use them for normal myelination, like this bright stripe of the posterior limb of the internal capsule. You look for foci of ischemia. They can appear bright on T1 because the background white matter is dark. It is not yet myelinated. And of course, hemorrhage can also appear bright. How do you differentiate hemorrhage from, say, ischemic foci? Hemorrhage will bloom on T2 weighted images. And this sign of abnormal signal in the putamen and ventrolateral thalamus, we'll come to that very shortly. There's one pattern of injury that occurs more in preterm and those with congenital cardiac disease, and that is known as white matter injury in neonates. It is seen as punctate white matter lesions, and you can see some of these punctate white matter lesions. They can be diffusion restriction if you do them earlier on. If you do them a little later, the diffusion restriction will go away. There's a lot of debate as to what is the cause of this. There's one pathologic report from 2010 which showed that there was aggregation of microglia in these areas. So these are thought to be due to increased cellularity, whereas some still believe that these are tiny, small areas of infarction. So in terms of myelination, just to remember very quickly, it progresses from inferior to superior and posterior to anterior and from center to the periphery. In terms of normal myelination milestones that we should know about, in the preterm, it's only the dorsal brainstem which is myelinated. At term, this is a very important landmark. The posterior limb of the internal capsule is myelinated at 37 weeks and beyond. And then, of course, the rest of the brain will myelinate as time goes on. One quick thing that I wanted to tell you about is this increased T1 signal in the globus pallidus and in the subthalamic nuclei. This is something we used to harp upon a lot about 5 to 8 years ago. And we used to give these differential diagnoses that are put up over there. But as you do your modern imaging studies, you realize that a lot of these increased T1 signal in the globus pallidus and the subthalamic nuclei are often non-specific. This is a MR study that one of my friends gave to me from about a year ago. Marked increased signal in the subthalamic nuclei and the globus pallidus. And this was a completely normal neonate. And on follow-up also, many months later, there was nothing wrong in bilirubin or anything else. So this can be often a normal, non-specific finding. How to use T2 weighted images? T2 weighted images are great for looking at anatomy. They're also good for looking at gray matter signal. The cortical ribbon, as it develops and you form sulcation, is well seen. You should see a continuous dark ribbon all around the brain. The basal ganglia will show darker signal as time involves, and that is something you should appreciate very well. The T2 image is also good for looking at cortical enfolding and sulcal development. As we see, this is at 25 weeks, this is at 29 weeks. Cells have become deeper, tortuous, and thicker. And by 34 weeks, all the primary cells are present, and most secondary cells are present. And as you go on to term, this is what your brain should look like. One caveat over here, because this is a mistake I made many, many years ago. The frontal areas of the brain and the anterior temporal areas of the brain are often flat, and sulcation and gyration in these areas, the frontal and the temporal poles anteriorly, develops even after birth. So don't consider these flat areas as abnormal. This is just normal. So let's come back to hypoxic ischemic damage in the newborn. It depends on the severity of the hypotension It depends on the timing of the insult, like I told you, and then it depends on the duration of the insult. So these are some patterns that we should be familiar with. One is the acute profound pattern, which usually indicates a very rapid and catastrophic injury. This often correlates well with a sentinel injury during labor, a sentinel event like placental abruption, severe hemorrhage, a tight cord around the neck, severe uterine contractility, and things like that. And in this, what happens is the basal ganglia is affected much more than any other area, the ventrolateral thalamus and the posterior putamen, and the perirolandic cortex. The intermittent pattern is when the ischemic injury occurs over many hours. And this can be due to, say, a sustained or increased uterine contractility, intermittent compression of the cord during contractions, increased use of oxytocin. In these areas, because the ischemia is over a long period of time, it is more often occurs in the watershed areas, not in the basal ganglia. And then, of course, both acute, profound, or intermittent, if they last for a long time, will become the total anoxic injury or the mixed pattern of injury, where the deep gray matter and the white matter are both involved. One important thing to understand is these are conceptual patterns of injury, and there's a lot of overlap. That's why we say basal ganglia dominant or watershed dominant, indicating that majority of the injury was related to an intermittent pattern of ischemia, or majority of the damage occurred due to an acute profound sort of pattern. There are two other patterns to know of. One that I showed you, multifocal white matter injury, which was very well known in preterms, but now we see that sometimes in term neonates also, and we see it much more commonly in those who have complex congenital cardiac disease at birth. The other pattern is arterial ischemic stroke, and we will not go a lot into this in this lecture. This is the concept of selective vulnerability, and I think Dr. Volpe popularized this. Important to know that areas which are damaged are those which are very active metabolically. For example, the chorothalamic groove is very active at 33, 34 weeks. That's why you get these reperfusion hemorrhages in the germinal matrix. At 34, 36 weeks, the paratrigonal white matter, there are oligodendrocyte precursors which are very active. So you get damage in those areas. Whereas in term, the basal ganglia, the perirolandic cortex, these are active metabolically, and these get damaged with ischemia and hypotension. This is just for the residents and fellows, a very classic case of periventricular leukomalacia. This is classic history of somebody who was a little preterm at 34, 35 weeks, had ischemia and hypotension, and what happens is the damage occurs mainly in the peritrigonal areas. You can see white matter loss. You can see the splenium is thin. This is a sign that if you see, you know that something has happened in the preterm age. Just a little note that, if you have such injuries before 28 to 30 weeks, the brain does not react with gliosis. Whereas if you have it after 30 weeks, the more later towards term, more the gliosis you will develop. Just a little point to note. Let's come to this pattern of the acute profound hypoxic ischemic encephalopathy that I spoke about. Sorry, it's very dry over here in Toronto. It's the middle of May, and it's still like close to just above 0 degrees. It should be 17 to 18 degrees. But this has been a long, cold weather for us. So profound HIE. This was a term patient who had vasa previa and multi-organ dysfunction. So that's the T1. I put in the flare image over here. You will notice that flare images are not part of a protocol. And this is just to show you how useless it is. We only use it when we want to look for extra-axial collections. These are T2 images which show increased T2 signal, and these are diffusion images. So you can see how the diffusion is abnormal. This image I have magnified over here because you can see increased signal in the dorsal aspect of the putamen and the ventrolateral thalamus. And this is a very important sign which suggests very significant injury, and it's a grave prognostic sign. It's a sign of acute profound injury. So just to point that out again to you, this is what normal looks like. the bright stripe, and this is what abnormal looks like. So you lose the bright stripe because you have increased T1 signal in the surrounding areas. This is another case, just to show you what the intermittent prolonged pattern looks like. This was an MR done at 4 days. And this involves more the white matter of the brain, as is evident in the increased T2 signal and also in the diffusion signal. So that same case, if you can see, this was done at 4 days of age. 1 month later, what happens to those areas which are damaged? You get multiple cysts within this area. So this is called as multicystic encephalomalacia. And as you wait and image a longer time, this is 1 year later, those cysts sort of collapse. And what you're left behind is very severe white matter atrophic change. One thing you'll notice that even the thalamus is very small. And this is not because the thalamus is directly involved in the ischemia. This is because there's degeneration of multiple axonal white matter tracts. Remember that though the thalamus is considered to be a gray matter structure, it contains a lot of white matter because of its extensive corticothalamic connections. There's one important thing to understand in terms of hypoxic ischemic injury in neonates, and that is delayed necrosis. We are very familiar with acute necrosis in acute arterial infarcts, like we see in adults. You have overwhelming insult, unrecoverable energy failure, and you have immediate diffusion restriction and restricted ADC values. What happens in hypoxic ischemic encephalopathy, more often than not, you could have acute necrosis, and I'll show you an example, but the pattern of damage is more due to delayed necrosis. So you have a moderate insult, the child has problems during delivery and labor, they plan to do a cesarean, they recover, resuscitate the child. So that moderate insult goes away. But then there is transient recovery of the mitochondria. And after some days or some hours, you have secondary energy failure. And that is when actually you start getting diffusion restriction. The implication of this is that you need to time your MRI and diffusion imaging to detect the maximum amount of delayed secondary failure and delayed necrosis so that you can accurately prognosticate the outcome. So that's why I'm mentioning this over here. There's one other pattern that happens, delayed apoptosis, but there's no good imaging signature for this, and it is something which we cannot really measure very well. So just to show you about timing of DWI, this is a child who came in with severe asphyxia. Now, usually we don't image in the very first day of life, but in this case, they wanted to withdraw care. The cortical activity on neurophysiology was very bad. The child was completely limp, and clinical signs were showing that this child would have a very bad outcome. So they wanted to withdraw care. The MR showed some diffusion restriction in the deep gray matter and some diffusion restriction in the posterior aspect of the midbrain. And these are the ADC values. The parents, we disclose all details to them, and the MR findings did not seem to be striking enough for them to agree to withdrawal of care. So they wanted to actually continue to treat and see what was going to happen. So we did an MR again on the second day, and you can see diffusion restriction is increasing. And by 4th day, you have the maximum diffusion restriction. In this case, if you look, the cerebellum is what is normal. Everything else is bright on diffusion and was dark on this ADC maps. And it was like a total anoxic injury to the brain. This is like a super scan of an analogy for an isotope bone scan. So there was very gross injury, showing you how diffusion involves and why timing your MRI and diffusion sequences is very important. Unfortunately, this child died, and Dr. Bill Halliday lent me these slides. He's a neuropathologist. You can see the subcortical necrosis. You can see necrosis in the areas where there was diffusion restriction in the dorsal aspects of the brainstem. So that was to show you the timing and also to show an example of acute total anoxic injury. One thing that you can do when you're doing an MR is Sometimes we do a coronal diffusion restriction because in the neonates, the sinuses are not well developed, so there's not a lot of air, so we don't get susceptibility when we do coronal diffusion restriction, and you can get nice images showing you the true extent of damage to the brain. So in terms of timing, remember the diffusion weighted imaging is best. It peaks usually around 72 hours. A T1 and T2 weighted imaging, T1 particularly will show changes best after a few days, usually 5, 7, 8 days, but can be from 2 to 14 days. And then the late sequelae are the cystic changes that I showed you and the volume loss. Those are much later. So when should we perform MRI? We perform an immediate MR only if the presentation is very atypical. For example, if the child has been born normally and there are seizures, focal seizures, we often suspect arterial ischemic infarcts. Their presentation is usually they have seizures after 6 to 10 hours after birth. Or if there is trauma, like in this case, or other things, or if you want to withdraw care, the child is clinically so bad. Our usual thing is that cooling goes on from 6 to 72 hours, and anytime after 72 hours, as early as we can, we would do an MRI. And then follow-up MRs we do at 7 to 10 days in selected cases. If we had some confusion, if previous imaging was inconclusive, this is one that we had recently where there was some thalamic increased diffusion. We thought it was due to deep internal cerebral vein thrombosis, and that's why we repeated it to confirm it. It wasn't the classic pattern of hypoxic ischemic injury. Just to show you how it evolves, this is courtesy Dr. Ching Chang Wai, my good friend from Alberta Children's Hospital. This was done at day 4 of life. And you can see that there was some diffusion restriction. There was some T1 signal. When you repeat it later, the diffusion restriction has gone away, but the T1 signal, the grave prognostic sign of ventrolateral increased T1 signal in the thalamus, and the increased signal of the posterior putamen is now very obvious and prominent. So it does help in some cases where findings are subtle or if findings are unequivocal to follow up the MR. And when we do follow up the MR, we do it as a very limited MR. We don't do all the sequences again. So this is what we do at sick kids. We do MRs early on at 72 hours, immediately after cooling has ended. And then we may do a delayed MR at 7 to 10 days. Let's come to medical legal aspects, and I'll be very brief on this because it is a very vast topic and very complex. Most often the questions that come up are causation of injury, and those patterns are very good to sort of describe that. The timing of injury, I want to say that timing is very difficult without everything together. It often cannot be pinpointed to within half an hour to 20 minutes like some people do. It can be only approximate. And then they want to talk about prognosis and rule out other causes. So remember that when we are going to speak to the judicial systems in any country, one thing we should do is not speculate, stick to what you know. And if you don't know, say you don't know. Remember that the duty lies to the court, not to the lawyer who has hired you. If you are an expert witness, then you will be paid by somebody. You have to be very consciously remember not to be biased. It can be difficult, but if you don't do that, you will get into trouble because if you do not stick to the facts and to your specialty and what you know, you will be held up to it. In courts, they go into every detail of every fine word that you have said. So you have to be extremely careful. So these are the patterns again in terms of timing. Now this intermittent prolonged pattern is a very wide spectrum of timing, can be many, many hours. The pattern which really comes close to where you can time it very well, particularly if you have a sentinel injury like placental abruption, is this profound hypoxic ischemic injury, which is more the deep gray matter or the basal ganglia dominant pattern. The other patterns, both of these, if they last long enough, you can go from intermittent to total anoxic and from basal ganglia dominant to total anoxic pattern. In terms of prognosis, how reliable is MR for a bad outcome? And this is from this particular meta-analysis. It is a very good one if you want to read. The positive predictive value was good. Many things were good, but this is an old paper from 2010. Many of us who do a lot of MRs, neonatal neurologists, and pediatric neurologists believe that the reliability of MR is even better than what that paper suggested if it is timed well. There's one thing that I want to focus on over here is there was a paper which showed that lactate NA ratios perform the best. You see this sensitivity and specificity, that's great for predicting an abnormal outcome. But to be honest, when we use MR spectroscopy in real clinical practice, the results are not the same, so that is difficult to translate in clinical practice. MR spectroscopy, the way it is used, is different. Every machine will show a different result, and it's very, very difficult to quantitate. At best, it is a semi-quantitative technique. So just remember that caveat that I told you, that we use it to determine lactate, but to determine accurate ratios is sometimes very difficult. Let's come to differential diagnosis. And I think I will have another 5 to 7 minutes before we take questions. So in terms of differential diagnosis, this is a patient with maple syrup urine disease. And you can see that presentation was a few days after birth. And the classic pattern is diffusion involves those areas which are myelinated at birth, the internal capsule, the dorsal brainstem, the deep cerebellar white matter. And these areas, if you look at T2 images, also show swelling, which is a good sign. So if you see this sort of pattern, whether you see it on MR, you can see this sometimes well on even on CT. Even if you're a resident, please raise the diagnosis of maple syrup urine disease, because if they can diagnose this very early, they can treat it. This is actually intramyelinic edema. It's not ischemic restriction. So it can reverse if treated very early, and you can have a better outcome. This is another metabolic disease, non-ketotic hyperglycinemia, much more rare, can present in a similar manner to MSUD, but in this case, MR spectroscopy helps. And this was a glycine peak, which suggests that this is non-ketotic hyperglycinemia. Now, if you look at the glycine peak and you're familiar with MR spectroscopy, you remember that the glycine peak is almost similar to where myoinositol peaks are. So this is a MR spectroscopy at 30 milliseconds. And you can see that this is where myoinositol lives. Now, myoinositol has a very short echo time. So if you increase the echo time to detect your MR spectra, say 144 milliseconds, myoinositol should get suppressed significantly. If it remains there, if you see a peak in the area of myoinositol, that is glycine, and you can diagnose non-ketotic hyperglycinemia. Just to give you a little tip on how to diagnose glycine, abnormal glycine on MR spectroscopy. Notice also how lactate is upright at the short MRS and inverts at the intermediate echo time. There are other things that you should know about. You can have two things impacting the brain. This is what I call double trouble. So with hypoxic ischemic injury, the glycogen stores and glucose stores in the brain are already depleted. And on top of that, if you have a predisposing factor for hypoglycemia, that can have a synergistic effect of damage to the brain. And you can have hypoglycemia and hypoxic ischemic injury happening together. This is a very good paper from our institution, published in 2013, which one could refer to. In terms of normal appearances, I just spoke about hypoglycemia, so I thought I must raise this over here. When you do evaluate MR, always look for the bright signal of T1. In neonates, actually the anterior and the posterior lobes both are bright, and that can last for a few weeks. If you don't see a normal bright signal, but you see an ectopic posterior pituitary signal, remember that these kids could have more sustained hypoglycemia, could have other pituitary deficiencies, which if not corrected early on can have lasting effects on the brain. I know of one medical legal case where the radiologist has been sued for not detecting an ectopic posterior pituitary gland. So that's something important to note every time you look at a neonatal MR. Coming to differential diagnosis, this is a poster we did in RSNA 2 or 3 years ago. showing everything that is not HIE. Obviously, I don't expect you to read these small images and this small print. But if you look at the etiologies that we had, we went through all our MRs for the last, I think, 8 or 9 years. And the most common cause was HIE, of course, but you can have causes like stroke, trauma, infections, metabolic encephalopathy. We spoke about some of these, inborn errors of metabolism, congenital lactic acidosis or pyruvate dehydrogenase. Metabolic problems are some of the more common ones amongst this rare disease. Brain malformations and congenital tumors can also present very rarely as an encephalopathy. Now, in terms of differential diagnosis and impact on the brain, there are some other things that I wanted to show you very, very quickly. We still have 15 minutes, so I'll try to finish this in 5 or 6 minutes, and then we can go to questions. So this was courtesy Dr. Chin-Chang Wai, a beautiful case of, hemorrhage in the thalamus. Whenever you see hemorrhage in the thalami, or you just see intraventricular hemorrhage for no other cause, always look at the venous system, particularly the deep venous system. In this particular case, you can see the internal cerebral veins in the vein of Galen were thrombosed. And this patient also had a variation of a false sign sinus. Instead of the sinus communicating like this only, there is a small straight sinus. There was a large venous channel communicating to the superior sagittal sinus, which was also thrombosed in addition to the extensive superior sagittal sinus thrombosis. There's one pattern of hemorrhage which I want people to be aware about that happens specifically in neonates and very young children, and that is subpial hemorrhage. And this was described very long time ago, in 1972. What happens is you start seeing these hemorrhages in children which look extraaxial, but they dip into sulci along the surface of the brain. The reason for this is that the dural membranes or the PL membrane of immature brain like the neonate is not very closely applied to the parenchyma like it is in older children, like it is in adults. So when these subpial hemorrhages occur, they are extraaxial, they're not parenchymal, but they do follow sulci into the brain, and this is the pattern that you see. There's a very good article in the recent Stroke Journal 2020 on subpial hemorrhages by Dr. Mursky, who's a pediatric neurologist, and his group, Dr. Stens. We've heard them at the AJNR, and you can see this pattern of subpial hemorrhage. There is some controversy as to whether this happens due to trauma during birth. Does it happen due to thrombosis of superficial veins? This particular paper is very good because assisted delivery occurred only in 12%, and coagulation abnormalities occurred in 77%. And so a lot of these are supposed to be due to coagulation abnormalities, and they can cause, like in this particular case, lateral venous thrombosis, or sometimes if you have a primary vein of Labbé thrombosis, that can cause a hemorrhage. So I found this paper to be very useful, and I would suggest that if you're interested, please do read it. This is a poster that was presented at the last ASPNR meeting from, again, my friends in Alberta Children's Hospital. Very nice depiction of subpial hemorrhages. The etiology, again, venous thrombosis versus hemorrhagic venous infarct, coagulation, and other etiologies. One final thing I wanted to talk about is hemorrhages in the brain. One thing that we should know is during normal delivery, delivery by itself, birth of a baby is fairly traumatic to the baby and to the mother. These hemorrhages, which are small subdural hemorrhages that we see along the dorsal aspects of the brain, posteriorly in the parieto-occipital regions and along the tent, are very commonly seen. And don't mistake them for traumatic bleeds, or if you were to image a child 3, 4, 5 weeks later, these can remain a little bit. They usually resolve by 6 weeks. Don't mistake it for non-accidental injury. So it's very important to remember. So what next? We know that MR has made enormous progress. We have seen a lot of advances in treatment of neonatal hypoxic ischemic injury in the form of therapeutic hypothermia. cooling up to 72 hours. And the number needed to treat for additional beneficial outcome is 7. I'm thinking the next big step in MRI would be when we have MRs in the neonatal units, where we could use them and other techniques like, near-infrared spectroscopy, ultrasound, etc., to actually bring down this number further, the number needed to treat, and help more neonates improve when they suffer from hypoxic ischemic encephalopathy. There are, of course, better sequences also. I personally don't have a lot of experience with arterial spin labeling, so these are slides from Dr. Mylan Ho. This is just to show you what normal perfusion looks like in the basal ganglia. And this is in a patient who developed profound HIE. You can see the increased perfusion over here. You can see perfusion in the rest of the brain was less. And then if you follow this up 3 days later, there is hyperperfusion in the deep gray matter structures. This is a pattern that we have also seen when you follow with color Doppler ultrasound. And of course, this, if it was occurring in a preterm baby with germinal matrix, that's one of the reasons you get germinal matrix hemorrhages due to reperfusion injury. So to conclude, here are some take-home points. Hypoxic ischemic injury is the commonest cause, but remember the differential diagnosis. Remember, clinical details are very important, particularly in neonatal MRI. I consider neonatal MRI of the brain to be the most challenging part of pediatric neurology and most interesting and important to give the attention in full detail and do it properly. Optimize transport and technique. Remember, I told you about diffusion and what TR values to use. Be familiar with the appearance of the normal brain and know the different patterns of HIE. So thank you so much for attention. This is Toronto. This is our clinical hospital. This is our new research building. They're adjacent to each other. I wanted to also say thank you to our children. For us at Sick Kids, every child who walks in stands tall and is a VIP for us, and we try to do our best for them. Must thank all my neurology colleagues, our clinical colleagues, particularly Dr. Stephen Miller, who does a lot of research on neonatal neuroimaging. And I wanted to share with you, I've taken Maki's permission on this little video from Sick Kids. It really moves me every time I see it and reminds me that behind every image or every building that is a hospital or every structure that we see, there are these patients whom we impact who go through life in such a difficult way. Let me see if this plays well.
The undeniable.
The voice coming through?
Patient's name is Sakari. He has end-stage kidney failure. His mom says he's
Maki, can you hear the voice?
Okay, let's get him hooked up.
Maki, can you hear it well?
Yes,
Okay.
yes.
What have I become? My sweetest friend. Everyone I know goes away in the end. And you can have it all. My empire of dirt. I won't let you down. I won't make you hurt. If I could start again, a million miles away, I will keep myself. I will find a way.
All right. Okay, thank you so much for listening to me, and I hope that video was inspiring to people who are interested in pediatric neuro. We make a big impact in children, so I'm going to go through some of the questions. There's one question here about, will there be CME-Rs for this? I'll leave that for Maki to answer. I'm not sure. There is this question about asymptomatic term with choroid cyst and chorothalamic groove cyst in US. Do they need MRI or follow-up images? We don't typically follow them up unless they are symptomatic or they're very large, particularly the choroid cyst. I hope that answers that question. What is meant by watershed injury? Watershed injury is basically the intermittent prolonged pattern type of injury, which involves more the paraventricular white matter. So is the zones between the ACA terminal branches, the MCA terminal branches, and the PCO terminal branches. Any other questions? Any other comments? I would be happy to hear other people's experiences.
In the QA, there's a question.
Oh, sorry.
This one.
I saw the QA. And these are the questions. There is a chat box I'll open up. Okay, there are some questions in the chat box. Let me look at them. The question is, will you share PowerPoint slide? This will be on YouTube video, so you can do that. Maki will give you the details. How frequent seizures may affect the MRI findings in HIE? That's a good question. I don't know, honestly, because we do it only in the acute phase. For seizures to involve the brain, basically happens with status epilepticus. One thing I know that when they're in the neonate, they do their best to control seizures because we know it can damage the brain. What I probably didn't show you is that when we do an MR of the brain and when we discuss these findings, we also, in our meetings, discuss amplitude corrected EEGs for the neonates. Neurophysiological presence of seizures also becomes very important in prognosis. You know, the burst suppression pattern or depressed cortical activity can have significance for prognosis and damage to the brain. But in an acute setting with seizures in the MRI brain, in the neonate itself, there's not a lot of literature. I can't tell you much. In the older child, we know that there is hippocampal damage. When there is status, we know that there can be extensive damage in the brain if it is not controlled for a long time. So that was it. There's a comment here that the sound did not come across well. Was the sound okay, Maki?
No, it was okay. It was okay. All
okay. Let me see if there are any other questions. Somebody has asked about significance of mammillary body signal in HIE. We have not looked at that. We do look at the hippocampus though. The phonics can be abnormal. I'm pretty sure along with all that, the mammillary body can also show diffusion restriction, but I have not specifically studied it or read about it. When parenchyma of the brain is injured by hemorrhage or ischemia, how to differentiate between the two insults when we do ultrasound after a few weeks? On ultrasound, both will look echogenic and it's difficult to differentiate. How it evolves is that ischemia will become cystic within a few weeks. Hemorrhage also may show gliosis or cystic changes. So that is a difficult one on ultrasound alone. There's one question here. Is the putamen more commonly involved in HIE than globus pallidus? Yes, that is the classic finding. The globus pallidus is not a classic finding for HIE. There's a question, what is the best time for MRI in cases of suspected HIE? I showed the timing. The best timing is 72 hours or third or fourth day of life. One thing is diffusion restriction in most cases will evolve to its peak after 72 hours. Whether you're using hypothermia or not, that is the best time to do an MRI of the brain for the neonate. Thank you, Dr. Dua Barma, for your greetings. I see that. Ultrasound sensitivity in the diagnosis of neonatal encephalopathy. It is less sensitive and less specific, but in very good hands, if you can spend a lot of time doing an ultrasound of the brain, then you can improve the sensitivity. Now, we had a pediatric body imaging fellow who used to do great ultrasounds, but she would spend a lot of time doing the ultrasounds of the brain. And when we compared her findings with our MRI findings, most of the findings that we showed on MRI, she could show, but you have to be really dedicated, do it yourself. She used to spend 40 minutes, 45 minutes on each MRI of the, each ultrasound of the neonatal brain to get those findings. Is the dentate nucleus involved in HI? Usually no, it can be involved, but typically it is not. Do you mention hemorrhage related to birth in the report? Yes, I do. I say that there are small or thin subdural hemorrhages along the parieto-occipital tentorial region, and these are likely birth-related hemorrhages. How can we interpret Plick signal abnormality in extreme preterm babies? You're correct. We only interpret it in the term brain, so that's a good question. We don't look for Plick signal abnormality in the preterm brain. It's only after 37 weeks when you're supposed to have the Plick which is myelinated, and that is the only time when we would comment on that in terms of its bright stripe. So let's see if there are any more. I think we answered the rest of the questions. Some more in the chat over here. I think we should be okay now. I don't see any more questions.
So, thank you very much, Manno. That was really great. Thanks everybody for attending. I hope this answers a lot of your question and will help you for your practice. Enjoy the rest of Ramadan and Eid holidays. Appreciate Manno. It was really great to have you. I'll just remind everyone that we will stop here for the rest of Ramadan.
Thank you very much and happy Ramadan.
Happy to you as well. And I want to remind everyone that we will have our presentation on YouTube, but please remember this disclaimer that we use for the initiative, that this is only for education for the period of COVID-19. Thank you everybody and enjoy the rest of your day.
Thank you. Thank you, Maki.